Thank you, Dr. Parekh and Dr. Puri, for giving me this opportunity to speak on this fantastic occasion. I have been listening to this talk since morning, and it's been excellent session, first session where we talked about total ankle replacement, MIS, Ilizaro, and sports medicine. I'm joining here with Dr. Arvind Puri and Dr. Ruth Varrall. So we all are from Australia, and my name is Dr. Ramawat, and I practice in Sydney, Australia. So I'm going to talk about the forefoot complications, and then we move on to the other topics, pes planus, pes cavus, and then Achilles tendons. So here we start, complications of forefoot surgery. So the talk is, first we have some literature review where we talk about all different factors. And then the next will be the case discussion, which will be a much more interesting topic. So in the forefoot, we include about hallux first. We'll talk about hallux valgus surgery. We'll talk about the first MTP joint arthrodesis. Then we'll move to the lesser toes. We'll talk about metatarsals as well, DMMO, vials, lesser toe deformity corrections. And then we move to the lapidus procedure and some soft tissue cases as well, so, tendons complications as well. Now, in the literature, some patient-related factors, those can affect the outcome of your forefoot surgery. The most common is diabetes, and HbA1c is the predictor for poor outcomes. Smoking has been shown with poor outcomes. Inflammatory arthritis, especially when they are on any disease-modifying anti-rheumatic medications, is again a fine balance between stopping them or continuing them before surgery to have a flare-up of arthritis, or you're risking your patient for infection. Low vitamin D, vitamin C, calcium, and zinc has shown poor results. I usually, if I do any, especially hindfoot surgery, ankle replacements and stuff, I do a testing prior to that and supplement them. For forefoot as well, if they are in patients with high risk category, I supplement them with vitamin C, vitamin D, calcium, and zinc prior to the surgery. Poor patient compliance have shown bad results, and definitely the age. Now we'll talk about hallux valgus surgery first, and this talk is in general about hallux valgus complications, whether you do MIS or you open. So in older literature, the complication was as high as 50%, and recent literature shows about 10%, but that includes all the minor complications, including superficial infections and things like that. Reoperation rate is about 5 to 8% in the literature. Open versus MIS, at the 1 year mark, there's no difference, but yeah, as we all know, the early satisfaction is slightly more towards MIS surgery than the open conventional hallux valgus surgery. Now, common complications we're going to talk about here in this talk is recurrence or undercorrection, hallux varus or overcorrection, transfer metatarsalgia, avian of the first metatarsal head or stiffness of the first MTP joint, and then infection and hardware irritation. Now, recurrence is defined in the literature when you have hallux valgus angle is 20 degrees or IMA is 10 degrees or more. It's more common with the distal metatarsal osteotomies and less common with the lapidus or the first MTP joint arthrodesis. Now, anatomical factors, they play a role, such as hyperlaxity or increased TMMA. Patient factors, non-compliance, wearing shoes, those are high heels or small box or neuromuscular disorders. And surgeon factors, inadequate correction or inadequate fixation. Now, algorithm, which we all learned when we did our foot and ankle fellowship, is to, for mild deformities, we go distal correction. For moderate or to severe, either you do scarf or proximal osteotomies. For TMT joint hyperlaxity or arthritis, lapidus is the way to go to prevent any complications. I personally do MIS, so I don't do scarf, but this talk is, again, as I said, in general about all the complications. Now, recurrence treatment based upon how the recurrence is, the patient profile, what's your long-term goals, how the patient's lifestyle is. Either you do Lepidus or you do first MTP joint arthrodesis, or you can definitely do revision fixation as well. So Lepidus has an advantage over, it has a long lever arm to correct. Also, you correct rotation, you correct intermetatarsal angle, and disadvantage is it's long recovery. You need to keep patient non-weight bearing afterwards, and it's invasive. It can cause transverse metatarsalgia if you shorten the first ray way too much. First MTP joint arthrodesis, the most commonly used construct is a dorsal plate and a leg screw. And early weight bearing is allowed once you have a stronger fixation, and recovery is also relatively earlier than the Lepidus procedure. Iatrogenic hallux varus is defined in the literature when you have a hallux varus angle. If this is more than 16 degrees, it will cause symptoms to the patient. Now, the causes are surgical factors. If you do excessive lateral release or too much of medial capsular tightening, too much IMA correction, or excessive bandaging postoperatively. To correct that, surgical steps, you just reverse what you would do with your hallux valgus surgery. You do medial release with VY-plasty. Lateral collateral ligament repair has been described in the literature. Either you use a suture button, or you can do a tendon transfer technique as well. EHL and abductor hallucis longus has been described in the literature, which can be used to your tightening of the lateral structures and moving your vector more into valgus. Now, bony correction is required if you have a bony problem. Reverse chevron, reverse scarf, and reverse Aiken has been described. We'll talk about a case later in the talk, which is one of my patients. If rigid, yes, fusion is the best option. You can fuse the first MTP joint. Malunion of the first metatarsal head. Excessive plantar flexion can cause sesamoiditis, so you need to be mindful of when you translate your metatarsal head. Excessive dorsiflexion can cause metatarsalgia of the second and third metatarsals. Varus and valgus tilt, it usually causes the change in the arc of the range of motion of the first MTP joint, and that leads to the loss of range of motion, and your patient can be unhappy about that. Treatment is, again, in mild deformities, you can manage with non-operative management. If it's severe, then you need to revise that. So either you do, for metatarsalgia, you can do either lengthening of the first metatarsal, or you can do shortening of the second and third, which is DMMO in my hands, or you can do Wiles if you prefer. In case of if shortening is an issue and excessive shortening, then you can lengthen the first metatarsal as well, which has been described in the literature. AVN of the metatarsal head is more with the distal osteotomy, especially when you do excessive release, especially on the plantar aspect of the capsule, where the blood supply lies for the first metatarsal head. With scarf is rare. It's asymptomatic. It can be left alone, but if it's symptomatic and depending upon the size, then after proper workup, and the best way is to put a bone block and then do arthrodesis and restore the length of the first metatarsal and achieve a solid bony union across the proximal phalanx and the vascularized first metatarsal. Hallux rigidus, we move on for the complications. So minor hallux rigidus deformity can be managed with chylectomy, where you shave off the dorsal impingement and give patient more range of motion. Again, as we know, arthritis is a progressive condition. 74% of patients will be happy, but rest will progress to arthritis, and they will require something in future. So when you do chylectomy, you need to tell the patient, yes, it's maybe the relief may be short-lasting. You may need something permanent in future if the arthritis progresses. Complications of chylectomy are progression to arthritis. 8% of cases have been shown in the literature. Under-resection can cause persistent impingement or failure of surgery. Delayed wound healing, postoperative infection is about 1%. Neuritis of the dorsal medial cutaneous nerve. However, it usually resolves in some time. Need for revision surgery in about 8% of cases. When you choose a patient for chylectomy, you need to be mindful of ruling out the functional hallux rigidus, which is a tightening of gastrocnemius, and the best way to check is when patient is standing, you need to check the range of motion of the hallux, and secondly, when you relax the gastrocnemius by flexing the knee, and you check the range of motion of the first MTP joint. So it's important to rule out the functional hallux rigidus. Now, resection arthroplasty has been shown in the literature for elderly and low demand patients. Again, complications are up to 65%. They can have a cock-up deformity or metatarsalgia and injury to the dorsal cutaneous nerve, which we just talked about. Joint replacement, hemicap has been an option for first MTP joint arthritis. Now, survival is about 80% in 6 years, so it's not a sort of good number to look at. Revision is harder due to the bone loss and need to bone block in about most of the cases when they fail. Cartilage implant, Cartiva, was popular probably 8 to 10 years ago. Luckily, I didn't put any before I started my practice. It was in favor, but then they failed miserably. About 36% was the failure rate. Subsidence was in about 90% cases. 50% patients would have some radiolucency around the metatarsal head. Orthodesis of the first MTP joint, if either you do open or MIS, it's a gold standard for the hallux rigidus in the advanced stage. Complications of non-union are about 6 to 8% of cases. Symptomatic hallux patients after complications will require revision surgery. Malunion is one of the complications of hallux rigidus. Now, usually malunion of the first metatarsal head is underreported, but 80% of them are dorsiflexion of the first first MTP joint. Now, if you have to revise after bone loss, it is with a bone block, and restoration of length is the main objective here of the first metatarsal and or the first ray, with allograft and a dorsal plate. Success rate is about 80% with this surgery. Now, moving on to the second or the lesser metatarsals, either you do Weil's or DMMO commonly done operations for the metatarsalgia. Indications are metatarsalgia, overload, or lesser toe deformities. Open versus MIS. Now, intracapsular versus extracapsular. Weil's is intracapsular, DMMO is extracapsular. Weil's osteotomy has been described in the literature a while ago in 1985. It's been around for a while. The most common complications are stiffness, because it requires excessive sort of release of the capsule, and also simultaneously you do lengthening of the extensor tendons. They can have a floating toe deformity. They lose control of the toe, which can be a reason of patient's disappointment. Transverse metatarsalgia of the remaining metatarsals can be an issue. Wound healing issue has been reported about 10 to 15% cases. CRPS is rare, but can be a quite significant complications, can affect the patients quite significantly with lesser toe surgeries. DMMO, or distal minimally invasive metatarsal osteotomy, as we say, is percutaneous technique. You preserve soft tissue. Again, common complications are floating toes or delayed union or transfer pain. Now, whenever I do DMMO in my hands, and 6 weeks time and 3 months time, you always see that they do have a persistent osteotomy site, and it's not healing, and yes, can be reason for patient's disappointment at that time, but usually it's self-resolved, and in the subsequent visits around 6 months, sometimes it can take 1 year, but it usually heals. So at 6 weeks and 3 months, reassurance is the all you need to do to your patient. Risk of excessive shortening and sagittal malalignment can be an issue with DMMO, because you don't control where the metatarsal head is going to go. After you do your osteotomy, it's going to float and it's going to sit where it wants to sit. In my experience, usually it's patients' expectations. When they come and see you at 6 weeks and 3 months, they want X-rays to be perfect. They want bones to be healed, which are not healed. And because of the nature of the incision, they always forget that they have something done with the lesser toes as well. And they do feel that they are still sore there, they still have swelling. So usually reassurance is the only thing they need at that point at 6 weeks and 3 months follow-up. Ongoing swelling is an issue at 3 months' time. Delayed union is about 5% of cases. It's been described in the literature by definition at 6 months' time if you see incomplete radiological union. Majority of them unite at around 12 months' time. So non-union is extremely rare in DMMOs, symptomatic non-union. It's about 1 in 1,000 cases. Malunion, if you combine with big toe surgery, because once they have hallux surgery, they tend to walk on the lateral bolt of the foot and they can displace the metatarsal heads where it should not go, but it still goes. Now, complications of lesser toe deformity correction surgery, hammer toe, claw toe, mallet toe correction. We do fusion of DIPJ, PIPJ, plus minus stenotomy or proximal filings osteotomy to correct the remaining of the hyperextension or varus valgus deformity. Open versus MIS. With open technique, use K-wires, use screws or specific implants to secure the deformities. Infection is the most common complications for lesser toe deformity correction surgery because of the nature of the injury, where the surgery is sliced and you have implants. Those are from out of this, from use your K-wire, which is can cause the infection. Usually, when you have infected K-wire, it settles down with removal of K-wire and oral antibiotics and proper wound care. Chronic infection, or if they have retained implant, it requires, which we, all the principles of open, of the written implants and infection, you need to debride, remove the implant, antibiotics, may require revision surgeries. Neuropathic pain is one of the complications of foot and ankle surgery, same with forefoot surgery as well. Sometimes there's no cause, mostly settles down. Usually I prescribe them vitamin C, 1,000 milligrams per day. Gabapentin is I put them on when I'm worried about CRPS or unknown origin of the pain, neuropathic pain, and finally send them to a pain specialist if necessary. Malunion of the PIP joint, either it is translation or hyperextension, and that can cause a disappointment to the patient because it can lead to the callosities and the overcrowding of the toes. Non-union, floppy toes due to over-resection, and you see a gap between the phalanges, and that can lead to the floppy toe deformity. Rotational issues can become an issue if it's fifth toe, because that can cause significant issue to the to your gait, and also with shoe wear. Flexor tenotomy, either you do dorsal incision or same incision you're using for your lesser toe surgery, and you can go all the way plantar and release it, or you can do separate incision plantarly. Plantar incision can cause painful scar, sometimes lead to recurrence. Flexor tendon lengthening, Z lengthening tenotomy can cause drop toe if you excessively release it, or if you under resect, it can cause hyperextension deformity. MTP joint instability can cause repair with plantar plate repair if it's causing persistent pain or a recurrence instability. Now, vascular insult to the toe, intraoperatively, if you see a patient with a toe that is not enough vascular, the options are you release the tourniquet, you wait till the vascularity is returned, or you lower the leg, you remove the bandages. If the wires are holding the toe, you can need to remove the wire in the sequence, and then nitroglycerin paste is the last option. And if it's not, then you need to sort of break the bad news to the family or the patient if by any means you cannot restore the blood supply to the toe. Lepidus procedure has been described in the literature for the hallux valgus correction. Again, the complications are non-union. In all the literature, it was about 6% to 12% of cases, but recently it's almost less than 1%. If you do bilateral together, yes, risk is significant in about 33% of cases. In my practice, I do only one side. I kept them non-weight bearing. If you do bilateral, you let them weight bear, and then you run into trouble of non-union. Now, surgical factors, there are three main factors identified. Those can cause the non-union. Number one, if you use a curette, which is probably not a better way of debriding the joint and removing all the cartilage. If you do resection, then you have much better joint prep, and it has shown less risk of non-union. Fixation device, if you use a plate and a leg screw, it has shown better result with a stronger construct. Two screws have shown higher rate of non-union. Early weight bearing, in the literature, it has shown that if you have weight bear after 6 weeks, the risk of union is almost 100%. But in some articles, they do mention that they put a plate and a leg screw, they can let them weight bear after 2 weeks. But in my practice, I let them weight bear after 6 weeks. Radiological non-unions are symptomatic, about 50% of cases, but rest 50% can be asymptomatic. Malunion, most common, is cause of the recurrence of the hallux valgus deformity. If you plantar flex the first tray, that can cause the issue of plantar flexion, such as sesamoiditis. Shortening of metatarsal is also can lead to the poor outcomes and patient dissatisfaction. If you shorten by about 5 millimeter, it can be tolerated. 5 to 10 millimeter can lead to, you can manage with some plantar flexion to compensate it. If you shorten by more than 10 mils, then you have to shorten the metatarsals by doing DMMO or wile osteotomy. More than 20 millimeters is not acceptable, and if that's the case, then you have to use a tricortical graft. Return to sports with lepidus, medial or plantar plate plus leg screw, about 100% patients you can achieve union, and about 85% of patients can return to sports. Now that sort of concludes the literature review, and then the next is we can talk about some cases here. So, Arvind?
Yeah.
So my first patient here is a 45-year-old lady, and she's from indigenous background, and she has a severe hallux valgus deformity, and her issue is she's unable to find shoes, and these are her x-rays. So we just focus on the hallux at the moment. She does have metatarsalgia of second and third as well, but hallux is her main issue. So question to Arvind and Ruth, whoever wants to go, what you would do in this scenario, whether you, osteoporosis is the main issue here if you look at the x-rays.
And does she have joint pain, sort of arthritic joint pain, sort of if you grind the joint?
No, she doesn't have any arthritic joint pain. The range of motion are pretty good. You can partially correct the deformity as well. And there is no hyperlaxity of the first TMT joint as well.
How old did you say she was, Sunil?
She is 45.
45, okay. So, I have a very low threshold when I see an X-ray like that to consider an arthrodesis as the first line of treatment for them rather than going for a correction. And even though she is 45, I know this sounds controversial, but if the deformity is extremely severe, inappropriate looking metatarsal, but with the intact IP joint and proximal TMT joint range of movement, which are pain-free and don't show any features of arthritis, I would be more than likely to offer them MTP fusion first.
So that's based upon your deformity or based upon osteoporosis or combination of both, Arvind?
combination. And if I have a very elderly patient, I'm again very inclined to offer them fusion. It is one procedure. Hopefully, if they don't have any complications, then that is all they need.
Yeah, I mean, she's 45, but yeah, considering her, her nutrition values and look at her bone as well, she looks much older than 45. I agree.
Yeah,
Correct.
I think particularly with the indigenous patients, sort of when we think of them as elderly, you're looking at 55 rather than the usual sort of 70 or whatever for a Caucasian patient. So I think from a biological factor point of view, you have to treat them slightly differently. I think I agree with Arvind. I'd go fusion rather than osteotomy, but I'd probably do Lapidus for her with an Aiken, because you'll get a really good correction with the Aiken to improve that pronation, and then you can straighten up that metatarsal and still maintain some movement at that MTPJ for her.
Does the degree of osteoporosis worry you guys? I mean, you say about fusion as well?
Wholeheartedly, yeah. I'm more of a scarf Aiken girl rather than an MIS, and so guttering when I do the scarf is a real issue if their bone quality is rubbish.
Okay, so I didn't do that, obviously, hence I'm presenting this case. I went with like these are the options we had, which we just discussed now, but I went with my conventional MIS, and I struggled a lot. So when I went in there, I did my like classical MIS osteotomy, slided the caput fragment, trying to hold in place, putting some wires, but there's absolutely no hold in the caput fragment. It was significantly osteoporotic. It's really like an eggshell. So there's nothing in there to hold it. Struggled a little bit, put wires a few times and screws, and then it was nowhere going to stop the fragment to fall back into valgus. Obviously, I wasn't prepared. I just prepared for MIS. I didn't appreciate the degree of osteoporosis. So the only thing I had in my operation theater that time was a old 3.5 millimeter T plate from a Synthes set, which was my bailout option. So I did put a plate there, held with the screws. I mean, I tried to put the plate on the medial, sort of medial side, so didn't want to fragment to fall back into where it was, but that's what I could manage. This is her after 3 months, and then the plate became an issue, started to hurt her, obviously. I did warn her after surgery that we had some issues and the plate needs to come out. So at 6 months' time, I removed the plate, and that's what she left with. But again, that's her foot. And by the time she had enough, and she said, look, I'm happy with whatever I got. Don't want anything else to be done. So lesson learned is appreciate the degree of osteoporosis. And I think as you guys both said, probably fusion, either you do proximal or distal MTP joint or Lapidus is probably way to go. Maybe would have looked at some sort of time as well. There's no rush. You can send them to endocrinologist and work on osteoporosis and see how they go with that part as well, if that's an option. Yeah.
Did you formally investigate her osteoporosis at all, like before?
I mean, after that, yeah, we did. I sent it for endocrinologist and all those things. So she got all the treatment for that. But that's after surgery was done.
Yeah.
So that was one. And then we move on to the second case here. So she is a good 30-year-old patient. She is a pharmacy student, and she likes to, wear her high heels shoes and things like that when she goes out. But she likes to run as well. So she likes to fit her shoes into the runners and likes to run as well. So when I saw her, that was her X-rays for the first time, and she got classical bilateral hallux valgus deformity. Again, first MTP joint is pain-free, full range of motion. TMT joint is not hypermobile, and she doesn't have any metatarsalgia. So to you, Ruth, what would you do here in this scenario here? What's your management? She has exhausted the non-operative management. She tried everything.
Yeah, so in my hands, she's a scarf and Aiken just because I do that rather than an MIS, but equally she'd do well with MIS. I suppose the question is whether you do one or both.
Yeah.
It's normally a conversation I have with the patient. It will depend on lots of factors, what support they've got at home, you're basically telling them that at least for the first couple of weeks, they need to be sat there with someone waiting on them hand and foot. So if they've not got that support, then they get one at a time. Same with sort of things like driving and stuff, whether that's going to be an issue for them. So I'm more tempted to do one at a time. I've had more complications when I've done bilateral than when I've done one at a time. And also I think they then, if you've got two at the same time, they compare instantaneously. So if one is subtly different to the other, they're immediately not happy with one of them. So yeah, one at a time is normally my preference.
And how much do you space them apart? 6 weeks, 3 months?
Well, I'm mainly public, so whenever I can get them back on the waiting list again. So for Central Queensland, that could be, 6 months to a year later.
All right. Okay.
I personally have had a slightly better experience, Ruth, with bilateral corrections, and I am like you and scarf aching. So from the very start, apart from all the points that you raised about the social support, what their jobs are, I think the couple of things that I want to know from patients is their expectations. What do they really want out of it, And the second thing is to give them a very realistic picture of, and like you mentioned, okay, I even surgery, hopefully getting the patient is a slide. So that, oh yeah.
Arvind, I think your signal's dodgy.
Yeah.
Not really. Just refresh your browser again.
So I just brought this in.
No, refresh your browser again.
Hey, Justine, can you voice down?
So now do you want to show us what you did, and then Arvind can tell you what
Yeah, sure. So I got your point, Arvind, as well. I mean, he's saying we do bilateral and he would do open as well. Look, I do MIS, and that's what that's how sort of I have my practices in the last 7-8 years. So these are the options. You do non-operative or operative MIS. We don't do MICA anymore. We do MITO, which is the transverse plus minus akin. Open is the scarf, distal, proximal. So I did MIS on her, and these are standard screws that I used that time from Right Medical. So they're 4mm and 3.5mm screws I used. So again, as you said, Ruth, correctly, she has two joint feet to compare, and she's happy with one and not happy with the other. So she's happy with the left, right she was never happy. And I mean, if you look at her x-rays and her presentation, then it makes sense that there's a malunion of the caput fragment of the right side. Slightly plantar flexed, slightly, you can see hallux varus, on the right side. And the joint as well looks incongruent on the right side. Now, so she was unhappy due to the mild hallux varus, and more so by supination deformity. She has issues with the dorsiflexion, especially when she goes out. She can't put any high heels, and she absolutely hates that toe when it doesn't go in dorsiflexion. And so issue here is it due to the change of arc, or EHL is entrapped into the capsule, or it's capsular tightness? So I did all the testing, ultrasound, clinic examination, and again, my thought process at that point was probably I'll do something minimum, like non-operative was not an option, so either do something minimum, maybe remove the hardware, do a bit of EHL tenolysis, and hopefully she'll be happy with that, or do a full correction. So obviously I decided not right, but let's go back here and tell me guys what you guys would do here when you see her unhappy at 3 months time and she doesn't have good arc of motion or dorsiflexion is limited.
Well, if she is confirmed on scans and your clinical examination that the problem lies with the correction and the positioning of the head, I would be revising her, and in my hands, I'll do it through an open approach. And if she was happy to have that undergo, that's what I would offer her.
So what's your algorithm, Arvind? How do you plan? Like, whether you revise the caput fragment, or you revise in the sort of proximal phalanx, or you do something to the joint, or how do you approach?
So depending on where the problem or the pathology is, right? So exposure is usually the same. It might be a bit more extensive, but you take the metal out that is there, right? You have through your previous.
Sorry, just 1 second. I mean, before you decide whether it's in proximal phalanx or in the joint or in the metatarsal head, how do you decide where the problem is? Is you based upon the scans, X-rays, or CT, or
CT scan? I get a CT scan, and I'm quite happy to look at the CT scans to decide the orientation and the angulation and how much. And I have no problem in getting the scan of the other side to see how much better or corrected that was compared to the bad side. But I would be telling the patient and counseling them that I'm going to do a extensive open procedure, removal of metal, correction, refixation, and any other additional soft tissue procedure that I think on clinical examination may help correct the situation.
So when you say you'll do this open, Arvind, so how far down the line is she? Because as a non-MIS person at the moment, that looks like 2 enormous screws and then a lot of fresh air in between the 2 bits of bone. Like, what are you going to use to fix it open if you're revising the metatarsal? How are you going to get purchase? What do you do? Like, I haven't revised an MIS like this, so.
No, I have not revised an MIS because I don't do it. But in my hands, if this patient, say, for example, was referred to me and was early days, then yes, I would be. And if the problem quite clearly was technical, then I would be offering it earlier on. If the positioning and all on the scans, clinical examination, or how much rehab she has had suggested that maybe you could wait for a little while, I would.
Yeah, I mean, I waited. I gave a bit more time. Again, I mean, she's unhappy, but you also sort of lying to yourself and you feel like, I think Arvind, okay, so you're lying to yourself. You feel like she may feel better. Just give her a bit more physio, tell her to a bit more work on dorsiflexion, and hopefully she'll be all right. Didn't happen. So I did obviously something really minimum that time, and hoping she should be okay. So I removed the hardware and did EHL tenolysis. So that's the after hardware removal. So she got a solid bony union of the first metatarsal. Hardware is gone, EHL is removed, everything is out, but she's still unhappy because she got this deformity. And she has limited dorsiflexion. So I did sort of open approach, obviously, to do EHL tenolysis and hardware removal. Now, this is like 1 year after that. So as Arvind said, I did a CT scan. I did a weight-bearing CT scan. And looking at the position of the caput fragment plus the sesamoids, after looking at the pictures, I couldn't sort of get my head around like where the problem is. But most likely, it's a combination of both the rotation of the caput fragment plus excessive aching. So now, Arvind, this is your CT scan, and does that help you to decide whether you would do procedure on metatarsal or proximal phalanx, or you do something to joint, or you do all of them?
She's also a bit short in that metatarsal as well. Is there, so the reduced movement, is it stiff, or she's just not powering her EHL properly because it's...
No, she has power. She has very good power. There's nothing wrong with the EHL. We did ultrasound. EHL is normal, intact. It's not tethered with anything. But
so if the metatarsal was short, then it's excursion to actually get full dorsiflexion. It's going to struggle to get full tension, if that makes sense. That was the only observation.
Yeah, correct. And I mean, changing the arc as well, because she got hallux varus now. That's changing the fulcrum of the, that's right, the arc of the EHL, and is giving her the stiffness. So unhappy. And
any problems with the sesamoids?
I mean, radiologically, now clinically, she did not have any pain. Only her issue was she didn't like the fact that she can't do dorsiflexion.
Okay, all right.
She was less bothered with the hallux varus, to be honest, and she didn't bother much with supination. Yes, she didn't like it, but her issue is she can't wear heels. So anyway, this time I decided to do, as you said, Arvind, the full revision. So I went in there, and this is her intraoperatively after we did all the corrections. So she's gone back into slight hallux, sort of physiological hallux valgus, and her dorsiflexion is this much. And if you look at the weight bearing, sort of mimicking weight bearing view, there is no supination deformity left. When she stands, she has this habit to stand on the outer border of the foot. She's trying to protect the hallux, so it looks like in supination clinically, but intraoperatively, she had absolutely no supination left. So I took these pictures just to show her as well afterwards. And my revision was, again, I did the osteotomy of the metatarsal. I derotated the metatarsal head till I was happy with the arc of motion. And as described in literature, I did a reverse Akin, so lateral closing wedge, and fixed with the screws. Now, I saw her recently. She's at 6 weeks after. She may be at 10 weeks now, but I saw her 6 weeks mark, and she was very happy finally. I mean, she stands with this funny position, but she's very happy that she got dorsiflexion about 40 degrees now. And she's absolutely, finally, she's happy.
Any metatarsalgia?
Not yet, and I don't think it will be, if it's not now. Yeah. The only thing which I was unhappy about this surgery at this point was that I can still see the joint is incongruent. I could have added some lateral capsular repair, but I was worried about making her more stiffer. Then I had it in my room. I was going to do it, but then I thought if I make her too tight, she may hate it again, because that could be an issue. But yeah, Tara, what you guys think about lateral capsular repair?
I've never done it.
No.
Yeah. I mean, I spoke to a few guys, that's what they said as well. I mean, you can add that, but I was like, probably, yeah, I wouldn't do it. Yeah.
Well, that's a much better outcome for the patient.
Yeah, I mean, at this stage, intraop, I was happy, and 6 weeks, she's happy. So I was like, that's all she needs. Yeah.
Cool.
The next one is a 41-year-old. It's a very interesting one. He's a 41-year-old male. He's a laborer, father of 6, and he never had a history of inflammatory arthritis or gout before. I saw him a while ago, 2021 it was, and he came with the pain and swelling in the first MTP joint. And at that point, it was for 3 months only, as he said. He said the pain is getting worse and it's really affecting his lifestyle. He can't sort of work as a laborer, can't look after his family. That was the issue. When I looked into the system, we found some x-rays done 5 years ago, and I asked him like what was wrong that time. He did not remember, but 5 years ago, he had a normal looking joint or normalish looking joint at that time. Now, when I saw him, that was his x-ray. So you can see bone and bone osteoarthritis. There's not much joint left. You can see dorsal osteophyte. You can also appreciate some swelling as well, soft tissue swelling dorsally and into the first web space. So I did an MRI scan. MRI scan showed this sort of cystic lesion in here. Now, here are the options. So, I mean, what do you guys do here? Whether you treat him non-operatively at the stage, or you give him some, you do aspirate the ganglion, send it from ultrasound guided aspiration, steroid, or you excise the lesion and then see what the result shows. Then you do something with arthritis, or you do both together. His issues are, it's painful and it's swollen.
Yeah, so I think, well, it's that usual conversation with the patient as to sort of impact on life, what he's done shoe wear wise, sort of has he modified his shoes, got a stiff soled shoe, all that kind of stuff. Invariably, by the time they've come to us, like they've tried all of that.
They've tried all those things, yeah, nothing working.
Surgical solution. And I think, that looks very much like a ganglion. You'd probably get an MRI just to see where it's originating from. And then treat the arthritis, which is probably the origin of the ganglion as well, and just make sure you've traced it back and got rid of it. I do a open fusion, I plate and screw.
Okay, and you excise the ganglion in the same setting?
Yeah.
Okay.
You presume
you normally do your open approach. Do you do dorsal or you go medial for your
dorsal?
In general, dorsal. Okay.
Because I do cup and comb reamers, so it's the easiest way to open the joint up to do that.
And you, Arvind, what's your thoughts on this patient at this stage?
Yeah, when I'm looking at the MRI and the history, He had no neurological pain, I take it, from any compression of the nerve within the web space, I take it.
Now, at that time, he only had dull pain, and that's
Yeah.
also in the first MTP joint, and the swelling is quite a big one, and as you can see in the X-ray, sorry, in the MRI scan, and that sort of is discomfort. He can't put any work shoes, he can't work, he can't play with his kids.
I mean, if you're convinced on clinical examination that the pain is quite a lot attributable to the MTP arthritis, then I would do what Ruth has suggested. Go dorsally, take that multiloculated cystic lesion out, fuse his MTP, and see how he does. If you're not convinced, then I would take the lesion out, give him a steroid in this MTP, and see what relief he gets. And if he says that really worked wonders, you could then go back and do something for his toe. But if clinically you're convinced it is an MTP arthritis along with an associated cystic lesion, then yes, dorsal approach and do both.
Yeah. So after MRI scan, as a normal practice in sort of Sydney, we discussed with the sarcoma unit, making sure we're not missing any synovial sarcoma and going in there. So I did discuss with the sarcoma unit, and they were happy with the pictures, that it doesn't look suspicious, and they were happy for me to manage. Otherwise, I would have sent him to see the sarcoma specialist. So I did, as you guys said, I did dorsal approach, and I excised that lesion, did cup and cone, and put the plate. I didn't use the leg screw, not sure why. That time I used to use the leg screw as well, in addition to the plate and screws. And then we sent specimen. The specimen came back, and that's how the specimen shows. I was hoping it would say ganglion, but it says this thing. It says inflammation and congestion, mild, non-specific chronic inflammation and congestion. Not sure what it means. They don't say anything, any name to this lesion. They do say it is non-malignant, which is reassuring, but they didn't specify what it was. So time passed, 6 weeks, he came. His pain is less, but he got this swelling coming back onto the big toe. It's mainly a diffuse swelling than localized swelling in the web space. And now swelling is mostly on the dorsum side, dorsum of the foot. It's very firm and woody consistency of the swelling. So I was worried about infection, obviously. Did CRP, which was normal. At that stage, I just reassured him that it's maybe just how you're healing, and sometimes you can get this quite a large amount of callus, and that can probably affecting your that's affecting the soft tissue. 3 months time, he came back again, and now I'm a bit worried. This X-rays look something is happening to the proximal phalanx and the distal metatarsal. You can see a lot of periosteal reaction, some sort of osteolysis around the orthodesis side. So what do you guys think at that point? CRP is normal again?
Yeah, I agree. It's not right. So you want to make sure that this isn't some sort of low grade infection.
Yeah.
Probably a role for a white cell labeled scan. I don't use them that often, but this is probably one where actually targeting the white cells would be useful, whereas a SPECT or whatever will just be hot everywhere. I know our ID team would probably want a sample. Again, at this point, having, make sure he's not been on any antibiotics. Often find with things like this, the GP sneaks them antibiotics intermittently, and you've suddenly realised that they've had weeks of antibiotics without you realising. So yeah, I'd get a fresh sort of biopsy type sample, do a white cell scan, and then probably discuss it with sort of the MDT with ID. Again, run it past the sarcoma guys, because something's not quite right here.
Arvind, you agree?
Yeah, I living up in far north Queensland where I am, infection is by far the commonest problem we face with that kind of appearance. I'll have a really low threshold of going in, doing an open biopsy, soft tissue, bony, send lots of sample for prolonged culture. There's lots of organisms we grow up here which don't go in the 5-day standard cultural that the labs do, So we always ask for prolonged, which can go even up to 12, 14 days. And then we end up growing something. And if you hit the right bug with the right antibiotic for the right length of time, you could be on to a win. But yes, I agree that a white cell labeled scan would be useful, but I would straight away go for a biopsy.
So I don't have
The
the.
question is whether you take the metal out at that biopsy and just leave him with a sort of slightly flailed joint, but at least native tissue to then come back later. I know our ID team don't mind putting fresh metal into infection, but if you've got metal where infection already is, then you're doomed to failure.
Yes, at that stage I was worried, and I had all these thoughts in my head as well. We did a normal bone scan, which was showing increased uptake, but white blood cell was negative for him at that stage. Now, CRP was normal, and then I decided to, obviously, as you guys said, I went in there and decided to take everything out. So I went in, removed everything, wasn't brave enough to take out that broken screw. I thought I'd just leave it. Hopefully we can get some meaningful specimens and give him some antibiotics, he'll get better. Then I come back again to fix it. At that time, I was thinking, and hopefully I can remove that screw at that time, if necessary. So, as you said, Arvind, we did for testing for everything. We did MCS, classical gram positive, gram negative, which was negative. The extended culture was negative. The testing for Mycobacterium DNA with PCR was negative. The fungus was negative. They did DNA testing for fungus. There's no filamentary fungi or yeast was positive, and they waited for 6 weeks. So ID put him on IV vancomycin, then I gave him some oral Bactrim, just prophylactically. He never grew with anything. So, and they did the 16S RNA as well, was negative. So finally they got sick of him and they said, we don't know what's wrong with him. It's been sort of 3 months of treating him with antibiotics. He's not improving. And his toe is not painful, but it's swollen like really firm, like wood. He would come to my room, sit there, ask me the questions, what my next step is, what's wrong with me. And I had no idea till that time. Constant phone calls with the ID consultants. We discussed in our mortality and morbidity meeting, and every time we don't know what's wrong with him. Anyway, time passed, 6 months. That's his toe was again showing some sort of unionish or healing, but main issue is the swelling. And if you can see in the lateral view, his toe is like a big sausage, it's like massive. He just doesn't hated this toe. What do you guys do now at this stage? What's going on in your head? What is the next option? Whether we missed anything initially or
like it's behaving like infection, even if we've not managed to grow it. So like if it was a diabetic foot, which I do a lot of, then I'd chop out the joint or where the joint's supposed to be, fill it full of cement, put a K-wire down the middle of it, and try and get some sort of bony union that way.
Yeah. Arvind, agree?
Yeah, but I'm really not sure. See, we are just kind of, just stabbing in the dark here, really.
Yeah.
Yeah, so you didn't grow anything. I'm assuming there would be investigations done to see if you had any other non-infective but inflammatory process going on.
Yeah, so I mean, we did blood tests, we took specimens out, and we sent for histopath. I mean, didn't show anything like crystals or pseudo gout and those kind of things. So yeah, really not sure. But that part was also sort of checked in this process of 6 months of multiple clinicians looking at one person, including rheumatologist and orthopedics. So obviously, team was involved and ID was involved, so we looked into those things. But yeah, no idea. Anyway, as Ruth said, I did the same thing. I went in there, removed the broken screw, put some cerament, and held with some K-wires. I did debride the joint this time. I mean, whatever I could debride, and then put some cerament, put some wires in. That was around 9 months.
How long did you leave your wires in?
Oh, that's a very interesting story, actually. So he lost one wire in, for memory, I think within 2-3 weeks. He found it was in his bed somewhere. So I put the wires, I put some German balls and found one wire in his bed somewhere. Other wire got buried in the soft tissue. So it was left out like a centimeter, so it doesn't get buried in the skin. Problem was one wire got pulled out, other wire got buried in the So this time I removed the wire somehow with some locals and stuff, and that's how he was at 9 months' time. We did MRI scan as well that time, showed this intramedullary sort of changes, and that's his picture was.
And did you drill up the canal with the CERAMENT as well, or that intramedullary?
I went to these holes and I made some multiple holes and drilled, not to the proximal metatarsal. I stayed in distal metatarsal.
Yeah, okay. So that stuff isn't from the CERAMENT.
That's not CERAMENT now.
That's what CERAMENT will look like as well. And we sent histology like later on to make sure that this wasn't tumor.
Yeah, at this time as well, it was sent again and again.
Yeah.
ID
Still no tumor.
No. And he had antibiotics holidays as well every time we went in there.
Yeah, it's
there was no antibiotics basically after 3 months because ID was sick of it. So we would only give him antibiotics after the surgery for like 48 hours and then we stop.
Yeah, I'm honestly no idea what it could be.
Yeah, so after 9 months, and recently when I was including him in this talk, we called him and we found he's not picking up his phone. His address is not, he's not there either on his address. We tried, so not sure where he is. He moved house or something. Anyway, I haven't seen him for the past 5 years, so yeah, no answer. Yeah, so do you have time for next case, Arvind?
Yeah, that's fine. Mine probably won't run the full hour. So
well, let's do the next one. There's one more case here. I got a 54-year-old guy, male. He is a warehouse worker, and he's medically very well, non-smoker, non-diabetic. And his issue is he just can't find he can't wear his work boots because his foot is just too wide and wide on both aspects. He's got hallux valgus, and he also got a penny neck deformity, and he also got metatarsalgia of second and third metatarsals. Again, the first MTP joint is not irritable. He got classical callosities on the plantar aspect of the second and third metatarsals. Now, Arvind, what do you do in this situation? You have this patient, this X-rays.
So look, if on clinical and history, it is quite clearly that the hallux valgus deformity along with the bunionette and the widening of the forefoot is causing him functional impairment. And he's also got metatarsalgia from the second and the third metatarsal heads. Then in his case, it won't be a bad idea, since he has to be doing a lot of work, being one of these warehouse people, to try and see if you can correct the middle two by doing the Weil's osteotomy, shortening it up, looking at the PIP, TIP joints to decide if they need anything done, and whether you would do something for the extensor tendons depending on the degree of subluxation or stiffness in the IP and the MTP joints. For the bunionette, it's quite simple. You can do a chevron, translate, but don't have to fix it. For the bunion, I will have a discussion with him whether he would be, if he's not a very like a sporty person or takes part in certain activities which require the hallux to be mobile, I would fuse it. If not, then yes, I would give him a correction with a word of warning attached to it. That's what I would do.
So you do fusion, first MTP joint fusion, you mean, or Lepidus, you mean?
No, first MTP.
Okay. That's because of what, the degree of displacement or?
Correct. And if he is somebody who's got a bit of pain at the end of the day from it all, and his shoes are what is really giving him more trouble, it'll be one-time correction, and that hopefully will help him, unless he is involved in certain activities that require MTP movement.
Okay, we'll come back to that. And Ruth, what do you do in this situation? What's your thought?
These actually fill me with dread. Like, these are the ones that I find the most difficult to correct. The ones with the super, super wide forefoot, sort of like a flipper almost. And I think the challenge if you did an MTP fusion is that you're not going to narrow the width of that foot all that much. And when you look at the angle of that TMT, I think that's probably where most of the deformities coming from. So yeah, I would have that conversation whether you can, if he's young, a scarf aching, if he's a worker, he'll have good bone, or otherwise I'd do a Lapidus rather than an MTP.
Yeah, I mean, if you look at X-ray, it's more the hallux primus varus deformity, which is rising from the the first TMT joint. So that was my thought process at that time, whether I do Lapidus on him or I just do what I normally would do for bunion correction. But Arvind, if you do first MTP joint fusion on this one, what's your approach? You go medial or you do dorsal approach, and how do you sort of position your proximal failings on this one? Because to me, it looks like it's, even if you fit a plate, just fit a plate, I think it's going to be a really wide forefoot even after you put the helix on the metatarsal.
So my approach for doing MTP fusion is mostly medial.
Okay.
And then lift up the whole full thickness flap, go right across, and then you can correct as much as you want without, of course, in any way impairing the blood supply to the metatarsal head. As long as you're aware and keep those tissues protected, you can get a reasonably good correction with an MTP fusion for these. I agree that the problem is at the TMT, and that correcting there is more likely to give you a narrower foot. But overall, when you correct that part with the MTP, which is more predictable in my hand, and the bunionette, and shorten the metatarsal with the toes itself, he may get enough narrowing to be able to do what he wants.
Okay. Yeah, so obviously I didn't do that. I did what I felt like it, and I did. These are the options as we just discussed on all these options. Scarf, as you said, Ruth, and you do scarf, and you do first MTP orthodesis. But I did my conventional mica. So again, how I look at these is, if I feel like I can still narrow the forefoot for him and give him a forefoot that's narrow enough, I can hold them in place with some screws, and the bone, if we can get him unite, then that's a win. So in Lapidus, I just get a bit nervous about keeping them non-weight bearing for 6 weeks and then waiting for 3 months and then worried about non-union stuff. So I try to avoid if they don't have arthritis or hyperlaxity. So I did conventional MIS, 2 screws, and obviously, for bunion net deformity, did chevron MIS and then did the slide, and then I hold them in place with the steady strips for 6 weeks. Now, second and third, I did DMMO, and again, as we know, where they're not sitting where they should be sitting, but again, they like to sit where they find the best place to sit, and by doing this only, we get correction of the second and third toes. If you look at the pre-op, the second and third toes also sort of got this Windsor deformity, which is not there anymore. So that's him at 6 weeks.
That was good. Like I'd be quite pleased with that.
Yeah,
the metatarsal head is sort of not supported. It's almost 100% translation, but that's where we found the best fit for the deformity correction. Again, sesamoids look reasonable. That's him at 3 months' time. We can see the metatarsals DMMO is they are healing but not healed. Fifth metatarsal is healing. He was happy at that time. He went back to most of his duties. A year later, we did telehealth. He lives about 5 hours from Sydney, and he's one of the friends with. So he's a friend of a medical secretary, works in our practice. So we organized this remote X-rays, and he was happy with that. He started to feel the screw a little bit, and he was worried about the swelling, but that swelling was explained to him it's a screw. Year and a half later, he came and saw me in person, and that time, that's his metatarsal. It's all healed, looks one piece. He has been working throughout the period. The second and third DM was also healed. The GP did X-rays, so I didn't do this. They did X-rays only of the helix for some reason. The screw is proud. So that is one of the complications which I explain to my patient when they do MIS, that yes, sometimes the screw can become prominent later on, especially when you have a big deformity and the whole metatarsal is going to reshape itself and you have more bone formation on the lateral side and bone absorbs on the medial side, the screw can become prominent. So screws were removed at 18 months mark, and he's happy. I have not seen him. I saw him 6 weeks after surgery, and then he's happy now. Time for one more case. Arvind?
Yeah.
So this is the last one for me. It's a 42-year-old female, and she is a bit of a larger size lady. She plays netball still, and she did have gastric banding surgery and the fat reduction surgery and all those things. When she saw me, she was coming out of this being a big person all those years and trying to play netball and get back into sporting activities after losing weight and doing gastric banding surgeries and stuff. Her issue was that she couldn't fit in her shoes, and she works as a payroll officer in our hospital. So her job is sedentary, but she's quite active. So these are her x-rays. And both sides she was symptomatic. And again, right has less deformity, left is probably more. Okay, again, in what you guys do here in your experience, Ruth, probably need to left and leave the right.
Check she's not ligamentously lax, and she'd get a scarf aching on the left, and I'd probably tell her to crack on the right.
Any metatarsal, second, third, pretty long.
She did have on both sides, as per memory.
Yeah. And then she does have that lateral deviation of the fifth metatarsal as well.
Bunionette,
Is she symptomatic on a bunionette?
I don't remember. I don't think she was particularly, but her issue was hallux valgus on bilateral. And look, again, I agree, it's more left than the right, but she was sort of equally complaining about both, and she just wanted to get it done with, but that's what they say all the time.
Scarf and aching from me, open obviously, and maybe second, third whiles if she has symptoms with some callosities on the plantar aspect and pain and all that, I would offer it to her at the same time.
Okay. So I did my classical MIS on both sides. And look again, I don't think I did anything with the bunionette and no metatarsalgia either. So I don't think I did anything with those. I did do on the left side, the second toe proximal phalangostomy, just to correct the valgus of the second toe. But that's about it. Now, that's how she was at 6 weeks' time. She was sort of happy-ish. Now, this is 4.5 months. She's happy with the right side, which she was going to be because that has mild deformity. Left side, she has bigger deformity, and she's unhappy because she got a recurrence here now. Now, at that stage, do you guys intervene or you wait? Or if you do, what's your thought process? How do you revise? If you guys don't do MIS, somebody referred you this patient like this, what do you do? And she plays netball, Arvind.
So won't fuse her is what you're saying?
Yeah. Before
you can play netball with a fused big toe.
Yes, you can.
I mean, you can, but it's not fun thing. I mean, you can.
So it's early recurrence.
Yeah.
And that sesamoid is very uncovered.
Yeah, exactly.
Yeah,
I think I'd revise her with a scarf aching, whether that's a 1 or a 2 stage of taking the metalwork out and stuff. But and then I think you need to address that second and third, because
they look too long
if
now.
they were long before, they're now very definitely long.
Yeah, me too. I'd do the scarf aching, include the second, third metatarsal. And I'm not sure how much aching to do. It's usually an on-the-table judgment, isn't it? You do a bit of aching, and then you say, okay, this is pass the saw a couple more times, a little bit more until you're quite happy with it. So that would be another thing to consider if you want to do just a bit better.
And I think like that, it's almost more the rotation than the valgus actually for the aching. Right. I think that's where that's going to come into its own.
Yeah, so I had a discussion with her at that time, and I was going to revise her, and I did not feel that I could revise by doing another MIS or, as you guys do, scarf or aching again. But I mean, these are the options: MTP arthrodesis or Lepidus or revision. I did Lepidus on her, so prepped the joint and corrected from proximally. And that's what I ended up doing. And I think I did in one setting. I removed everything and did classical plantar plate, screw plus the screw between the second and the first metatarsal. She healed, and she was non-weight bearing for 6 weeks, and then partial weight bearing from 6 weeks to 12 weeks, and then she went back playing netball after 6 months. I recently called her before this talk, and I got her permission to present her case, and she was very happy to present, and she has been playing netball with no issues.
Cool.
Yeah. So take home sort of message from this talk is identify the dominant failure mechanism for your forefoot complications. Patient factors, they need optimizations. We can control their diabetes, or tell them to stop smoking, or optimize the nutrition before you proceed with the surgery. Instability or malalignment or shortening, to address those accordingly, whatever is the issue with your failure. Correct the cause, not just the deformity, and that would prevent you from having the number 3 or number 4 operations. Approach, you do MIS or open, it doesn't matter as far as you correct the biomechanics.
Right. No, that's fantastic, Sunil. It's really comprehensive presentation and really interesting cases, and quite difficult, to be honest. So I know I did introduce Sunil, but it dropped out. But I take this opportunity, first of all, to thank Selene for giving us this fantastic chance to present at such a prestigious and well-recognized educational event, and also to thank the Oxano Medical, who have very kindly sponsored the educational meet as well.